Hello everyone, this is Professor Yamini Bhushan Tripathi, former Dean Faculty of Ayurveda and Professor of Biochemistry in Department of Medicinal Chemistry, Institute of Medical Sciences, Banaras University. You know that we are interacting with each other under a 12-week certificate course on palliative care with integrative approach. And you know that it can be mixed pain. Under neuropathic, it can be central or peripheral. Central means central nervous system, post-stroke, multiple sclerosis, spinal cord injury, migraine, 31 million people are having, and HIV-related neuropathic pain, also very common. And peripheral means peripheral nerves like post-herpetic neuralgia. The herpes is the virus which affects your body, and then there is a nervous pain, very, very, very serious, very troublesome pain. And diabetic neuropathy is very common. Uncontrolled diabetes people have this. And visceral means internal organ, pancreatitis, inflammatory bowel syndrome are common, which is visceral. And mixed means lower back, cancer, and fibromyalgia. So now I am describing one by one what is the nociceptive pain and its mechanism. Nociceptive, free nerve ending. Nerve endings are exposed because you have an injury. Has capacity to distinguish between noxious and innoxious stimuli when exposed to mechanical trauma, thermal trauma, or chemical trauma. And then say the tissue damage occurs, substances are released by the damaged tissue which facilitate the movement of pain impulse to the spinal cord. Substances are released from the damaged tissue which facilitate the movement of nerve. You see, nociceptive caused by activity in neural pathway in response to injury. It can be post-operative pain, it can be mechanical low back pain, it can be support, exercise injuries, it can be sickle cell crisis, it can be arthritis. Anything can happen. Now, how the emotional stress, I told you, is very complex, how the emotional stress, trauma, anxiety, and depression induces pain. Very interesting. Psychogenic pain involves limbic system activation. Emotional processing center. Limbic system is a emotion processing system in your brain. Dopamine dysfunction and overactivation of area like amygdala, anterior cingulate cortex ACC, and prefrontal cortex, insula or amygdala, repeated. A hippocampus modulates the perception of the pain. You see, perception of the pain. Even the pain is not there, but you have a perception that pain is there without any physical stimuli. No stimuli. They send descending signals that modulate pain processing at the spinal cord level. So, second, reduce serotonin, reduce dopamine, reduce serotonin. They are the happy hormones. They are the happy hormones. If happy hormones are reduced, you have a perception that you are feeling pain. And non-epinephrine signaling, which impairs the brain ability to suppress pain. The happy hormones don't allow you to feel pain, but since they are reduced, you feel pain signal. And why it is activated? Glutamate and GABA toxicity. Glutamate excitatory and GABA inhibitory. Balance is disturbed. Last one, central hypersensitization, where neurons in the spinal cord and brain perceives normal sensation as pain. Hyperalgia, this is called hyperalgia. Suppose if you have a cut on your skin, and even then you don't feel pain, many people. But if some people see a nurse coming with a syringe, he starts crying, "Humko dard ho raha hai, humko dard ho raha hai." Why? Because psychologically he is not ready to receive that injection. So he is feeling, so he is afraid of pain, and he is saying, "I am getting pain, I am getting pain." but many people get a big damage, but even then they don't feel pain. So this is the psychological. Hypothalamic pituitary adrenal axis, HPA axis overactivation also leads to cortisol release, resulting in the pain. You know that cortisol is produced from the adrenal gland, and adrenal gland activity is controlled by ACTH. ACTH. It is released from the pituitary. If this balance is disturbed, more cortisol will come out, and you will have problem. Overactivation leads to chronic cortisol. Dysfunction in endogenous opiate system. Opiate system is a system which allows the perception of the pain in your brain. Endorphins are there. Opioid receptors are the receptor for endorphins. And endorphins is produced within the brain, which manages your pain, which is the natural brain's killer, painkiller. Okay? And neuroinflammation due to activation of microglia. Microglia is a macrophages present in your nervous tissue, brain, and astrocytes in the CNS. Their macrophage function is to release cytokines, inflammatory cytokines, and their function is to protect the body from the infection. So, if microglia are overactive, more pro-inflammatory cytokines will be released, enhancing the natural excitability and pain persistence. And neuroplasticity changes like synaptic remodeling will also create and neurogenesis inhibition, they will also create psychological pain. Now I am coming to neuropathic pain. Neuropathic pain, I have told you, like the diabetic patients, like the nerve damaged people, they have. If nerve is damaged due to lesion or a disease affecting the nervous system, then the nerve injury is the cause of the neuropathic pain. One line, nerve injury is the cause of the neuropathic pain. Peripheral sensitization during nerve injury upregulates the Na channel, sodium channel, increasing the axon potential, firing in nociceptive. The calcium channels are also important, they are upregulated. So, upregulation of sodium channel and upregulation of calcium channel are responsible for neuropathic pain. Enhancing the neurotransmitter release, sensitization, or heat and chemical stimuli, and high discharge of damaged ectopic neurons without any stimuli. This is the problem. Neuroinflammation triggered by nerve injury activates glial cells, microglia and astrocytes, releasing pro-inflammatory cytokines, which is also the cause of the pain. Third, central sensitization in spinal cord, dorsal horn, and the brain, resulting NMDA receptor activation. NMDA receptor activation, which further influences calcium influx, which further activates the PKC pathway, gene transcription changes, and COX-2 release, which is the inflammatory and pain-inducing factor. This induces the loss of the GABAergic and glycinergic interneurons, leading to reduced inhibition. Window phenomena due to altered gene expression due to persistent pain disturbs in ion channels. These ion channels are disturbed, then gene expression is also affected, which gives you the permanent pain effect. And descending modulation dysfunction. These are the main functions for the neuropathic pain. So, development of neuropathic pain, I have just summarized it: nerve damage, the metabolic, ischemic, hereditary, compression, traumatic, toxic, infection, and immuno-related. All these factors can damage your nerve. If nerve is damaged, mechanisms are there: spontaneous pain and stimulus evoked pain, and then neuropathy. So, this is the etiology, this is the pathophysiology, this is the symptom, and this is the syndrome. This is a summary of the neuropathic pain. The mechanism of peripheral and central sensitization. I have told you what are the receptors which are involved: opioid receptors, glutamate receptors, 5-HT receptors, GABA receptors, alpha adrenoreceptors, TRPV1 receptors, AMPK Ka receptors, sodium channels, calcium channels, P2X receptor, and ASICs. So all these receptors are disturbed, are involved in neuropathic pain, and their abnormal function is the cause. This slide I am again showing you the primary afferent and spinal lumbar dorsal region. This area, see, the dorsal region. This is if it is damaged, what will happen? So, physiological state and neuropathic pain. So, this is the I want to emphasize that damage in the primary afferent dorsal region of the spinal cord can cause you the neuropathic pain. So, these are the traumatic and hemorrhage brain injury, excitotoxic neural death, and peripheral nerve injury. These things will cause a nerve damage, and this nerve damage will cause a typical psychological pain model may include. Now I am describing a psychological pain and neuropathic pain. Both are related to nerve, but this is because of nerve damage, and this is because of nerve dysfunction. Psychological means dysfunction. Psychological trigger activates limbic system. Limbic system modulates the spinal nociceptive neurons, and then neurotransmitter dysregulation, and then reduced descending inhibition, and HPA axis activation, the neuroinflammation and cortisol elevation, and altered brain connectivity, so central sensitization and persistent pain perception. This is the summary of the psychological pain. The neuropathic pain involves the following molecular pathways: peripheral nerve damage, ion channel remodeling, spontaneous firing. In spinal cord, glial activation, NMDA receptor upregulation, and brain regions ACC and thalamus altered perception and emotion linked to pain. So this is the summary you can keep in mind especially for the medical people, and that what is the cause of the psychological pain and what is the cause of neuropathic pain. Now, if we are talking of pain, then we should always think the severity of pain, how to measure the severity of pain. Moderate to severe cancer pain, continuous persistent pain, not for intermittent or incidental pain. Continuous and persistent pain when non-opioid analgesics are inadequate. I told you there are two groups, steroidal, non-steroidal, and morphine group. So, non-opioid means it can be steroidal, it can be non-steroidal. Steroidal is not very good to treat because steroid is a life-saving drug. It should be only used when life is under threat. Otherwise, non-steroidal anti-inflammatory drugs are used. But if it is non-effective, the non-opioid analgesics are inadequate, non-effective, then, so this is the severity of pain, step 1, step 2, step 3. If pain persists or worsens, this is the sign. Step 1 means non-opioid analgesic plus minus adjuvants. Step 2, weak opiates. Now, if it is not effective, then weak opiates associated with non-opioid adjuvants. Non-opioid drugs plus weak opiates. Even then it is not controlled, then step 3, strong opiates associated with non-opioid and adjuvant therapy. All the three things are applied. All the three things are applied in this case. The pain diagnosis, when you are talking about the pain severity, Now, you should know how to diagnose the patient's severity. Step 1, as a caregiver, you are with the patient, you have to take this responsibility, how much you can tell, because you have to communicate the condition of patient to your treating doctor, palliative care team leader. Location of the pain, where is the pain? Onset, sudden or gradual? Nature, is it burning pain, stabbing pain, dull or cramping? Radiation, does it spread or it remains localized? And trigger and relief. What are the causes which trigger the pain and what are the factors which help, which relieve the pain? Step number 2, pain score. Then numerical rating scaling NRS from 0 to 10. I will show you the next slide. And visual and log scale line with extremes. By seeing the face of the patient, you can score it. And Wong-Baker face scale. This is the Wong-Baker face, especially for children or cognitive impaired patients, because they cannot write, they cannot speak. By watching their face, you can determine the severity of pain. So, documentation and communication. Once you do these two things, then document it. Caregiver report to doctor with pain score. What is the pain score? For example, 8 by 10 or 5 by 10, 6 by 10. Type of suspect. So, if it is burning pain in foot with tingling, likely neurotropic. Site and character of the pain, documented. Duration and frequency of the pain, documented. Any red flag, sudden severe pain or neurological signs, you have to document it and communicate to the team leader. Use of screening tools. What are the screening tools? LANSS, leads assessment of neuropathic symptoms and signs for neuropathic pain. PHQ-9 and HADS to screen the psychological involvement. So, they are the 4 things you have to do while reporting. The 5th one is, I have put a separate slide, how to identify the type of pain. I have told you there are 4 or 5 types of pain. As a patient caregiver, you are on the bedside. How you will identify and communicate, then the physician will come and he will finalize it. But at the first step, it is your duty to identify and report it. So, location of the pain, description of the pain, response to the opioid drug, examination findings, and associated signs. There are the 5 things you have to locate. Nociceptive, neuropathic, psychological, and idiopathic. So, localization means well localized, somatic or visceral, along nerve or dermatomes, psychogenic, diffuse and shifting and variable. Description, etching, throbbing, pressure, burning, soothing and tingling, vague and often emotional context, unclear. Response to opioid, often good, partial. Psychogenic, poor or variable. Examination finding, tenderness and swelling. Allodynia and hyperalgia, often normal. Psychogenic, often normal. Associated with injury and inflammation, numbness and weakness, anxiety and depression. So, if you find your patient with pain, having anxiety or depression, you can understand he is psychogenic pain. If it is numbness or weakness, it may be neuropathic pain. If it is inflammatory and injury in base, suppose the patient has fallen down, he is having a pain. This is because of the trauma. So, this is the scale, pain scores. I have made 3 scales. No pain, very happy. Mild pain, hurts a little bit. Moderate pain, hurts a little more, hurts even more. Severe pain, hurts a whole lot, hurts worse. Depending on the face, depending on this scale, depending on the face, and depending on this scale, no pain, discomfortable, distressing, intense, utterly horrible, and unmanageable pain. So these are the pain. This is another line, no pain, mild, moderate, intense, and so these 3-4 types of scales I have shown you. You can use, and this will be. We will take another class to tell you how to do it. Evaluation of the pain. This is here I am going to talk. The nature and intensity of the pain, current and post medication, its side effect and effectiveness, underlying coexisting disease, whether it is depression, hypothyroidism, how chronic pain has affected the physical and psychological function of the patient, history of the past and current substance abuse. Is patient on opioid from another provider? One can check with previous physician for details. Personal or family history of abuse, including alcoholism, etc. And urine drug testing should be done to find out what is the status of patient in taking opiates. And now, the current method of treatment, I am coming to the, up to now we have discussed about the symptoms of the pain, how to diagnose the patient type and other things. Now I am coming to the treatment part. WHO has analgesic ladder, stepwise approach, adjuvant therapies, interventional techniques, and non-pharmacological approach. First of all, see the ladder. Step 1, non-opioid analgesic plus adjuvant. Step 2, persistent or increasing pain, then weak opioid plus non-opioid adjustment. Step 3, strong opioid and non-opioid plus adjuvant, all the things. But you should do one by one. You cannot jump on this directly. Stepwise, non-opioid, weak opioid, strong opioid. Adjuvant therapies means antidepressant, anticonvulsant for neuropathic pain, corticosteroid or bisphosphonate for bone pain, interventional technique like nerve blocking, epidural injections, drug delivery, and this is neural disease. Non-pharmacological approach means psychological counseling, physiotherapy, or complementary therapies like music therapy, relaxation therapy, spiritual care. These things are the non-pharmacological approach. What is the substance abuse? Now I am coming to the use of morphine or opiates. This is a substance abuse risk is there, and because man becomes addicted for taking morphine because he have a pleasure in using morphine. So if even the pain is not there, he keeps on taking it. So there is always risk of addiction, there is always risk of substance abuse. So we have to be very careful. Substance abuse risk refers to the likelihood that an individual will misuse or become dependent of the drug, alcohol, or prescription medication, especially opiates in palliative care. This is a very important factor for the caregiver giver. That you want to give the comfort of life of the patient, but you don't want to become an addictive drug addict. You have to be very careful. This risk is crucial to assess before starting the pain management. So history of substance abuse, mental health disorder, family history, social environment, and poor coping strategies. These are the risk factors. Explanation: prior use of alcohol, tobacco, and illicit drugs. You should know. Mental health, is it depression, anxiety, or PTSD like patient? Family history, relatives with addiction issues. In the family, if people are drinking, there is a likelihood that this patient may also start the same thing. Social environment, peer pressure, isolation, and high stress setting. What is the social restriction patient is having? If he is not having any social restriction, no social responsibility, he is more prone for drug abuse risk. And poor coping. Pain leads to overuse to deal with emotional stress. So red flag requires for this condition requires for a specific drug by name e.g. only morphine work for me, a frequent loss of perception or early refilling request, resistance to non-opioid options, and mood swing and history of doctor shopping. These are the factors one should see. If suppose we have given the medicine for 10 days and he comes to you on 7th day, it means he has consumed 3 days, three medicines of 3 days extra. It means he is getting towards addiction. This is a red flag. You have to be very careful. Substance abuse risk assessment, how to do it? There's set norms like CAG-8 questionnaire. Quick 4 questions, screen for alcohol and drug use. Opioid risk tools, ORT, predicts likelihood of opioid misuse. DIRE score, D-I-R-E, DIRE means diagnosis, interactability of pain, R means risk factors, and E means efficacy. And drug abuse screening test, DAST test 10, general screening of drug abuse. And SOAPP, S-O-A-P-P, screening and opioid assessment for patient with pain. And SISQ, single item screening question. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical purpose? So these are the different protocols, different tools to assess the substance abuse risk in your patient. The class of medication. Now, what are the classes of medication which are generally used for your treatment? Mild pain, moderate pain, severe pain. I showed you the ladder, right? This is a part of the ladder. Any stage, local use. So, mild pain is non-opioid. Examples are paracetamol, ibuprofen, diclofenac. Caregiver note is the monitor GI side effect. These are the drugs which are having GI gastritis, gas formation side effect, kidney function, kidney damage is likely. So you have to monitor these two things. The adjuvant, if needed, antidepressant and anticonvulsant, gabapentin, amitriptyline, useful for early nerve-related symptoms. This is the adjuvant, this is the non-opioid. Moderate means weak opiates, tramadol, codeine, risk for sedation. These people who are using this, they are having risk of sedation, keep on sleeping for a long time. They start slow. In the morning, they will have laziness, and its side effects should be managed. And other supportive drugs like corticosteroids, ketamine, or like the palliative symptom control like anxiolytics, antipsychotic drugs can be given. And this is for localized pain, this thing can be given. Ensure correct site and duration of the application. So now use of morphine, because morphine is a narcotic, come under narcotics department. So government is very strict, and in issuing the drug, in marketing the drug, and as a caregiver, your responsibility is also to see that the drug which is coming for pain management should not be misused for pleasure. This is a very important part you have to take care. So indication, moderate to severe pain, continuous cancer pain, stage dose 5 to 10 milligram orally every 4 hours. It is a pharmacokinetics is very important, so we have to give repeated doses, not high dose, slow dose, but repeated, so that therapeutic response may continue. Go complete pain relief without sedation. High dose will induce sedation, the low dose will not induce sedation. That is it. Essential aid or add-ons. Always prescribe a laxative and anti-emetic drug. There is a chance of constipation, to use laxative and anti-emetic drug. Titration. Titrate slowly based on the pain relief and drowsiness. Drowsiness is a side effect. Pain relief is the therapeutic response. You have to titrate it. The patient should relieve the pain, but he should not go under drowsiness. Titration. Switch to sustained release morphines. Because 4-hourly management may be difficult, so now sustained release morphines are coming in the market. Use this. You can give one tablet after 10-12 hours, give another dose, or maybe 24 hours. Caution, avoid in intermittent, incidental, or non-cancer patients. Don't give it to the non-cancer patients, avoid it. And common side effect, constipation, nausea, and sedation, I told you. Pain-free without sedation is the goal. Now, is there a maximum safe dose for morphine? Increase the dose in step until the pain is relieved. Use the increment of 5 milligram, 10, 20, 30, 45, and 60 milligram, etc. Increase the dose every 4 hours. 4 hours is important. Any dose you are giving, give it the 4 hourly. If there is still pain, 90% of the patient will have relief within that of 5 to 60 milligram. If not controlled, then dose of, you can increase up to 500 milligram or higher. But most of the people get control up to 60 milligram. When to use, when not to use is important. Without proper pain assessment, don't use morphine. Intermittent bone pain, nerve pain, colic pain, or non-cancer patients, don't use morphine. Related pain, heartburn, peptic ulcer, and these patients should not use morphine. Headache, gastric distension, colic pain, there don't use the morphine because they have the side effect of the constipation. It will increase it. Best route for morphine. Morphine is effective by all routes. It can be oral, it can be rectal, it can be sublingual, it can be subcutaneous, it can be intramuscular, and can be intravenous. Depending on the severity of the pain and dose you have decided, you can use any mode of treatment which is acceptable to the patient. Dignity of patient is very important. Sublingual dose is equivalent to oral or rectal dose. When suppose the patient is not able to swallow anything, rectal dose like enema, medicated enema can be very effective because the drug is going to the body. He is not able to swallow. He is unconscious. The intravenous can be effective. When converting from oral to rectal to subcutaneous, cut the dose to half. Dose will change. Suppose if a patient is getting 60 milligram per day, and then his dose can be reduced to 30 milligram or 20 milligram. So this is the increasing dose, 4-hourly dose, 5, 10, 20, 30, 40, 90. And the 12-hourly morphine SI, this is sustained release. If it is sustained release, 12-hourly. If it is not sustained release, 4-hourly. So 12 hours benefit you get if you get a SR. Morphine intolerance, gastric status, sedation, delirium and hallucination, myoclonus, vestibular stimulation, pruritus, and bronchoconstriction. These are the major side effects of the morphine. A strategy to improve tolerance. Start with low dose of morphine and titrate slowly upward. Use short-acting preparations until established. Sedation often improves after 48 hours. If sedation has come after 48 hours, it will improve automatically. But in this 48 hours, if pain is not controlled, you have to repeat the dose. That is the problem. Pain may appear to be morphine resistant if underdosing. If dose are underdosed, pain resistance, morphine resistance may appear, so that you have to increase the dose. That is called the addiction. Consider alternative opiates like tramadol, fentanyl, oxycodone. These are the, keep on changing it. It may affect. Consider interventional procedures also, and often worth discussing with palliative care team. Consider other causes. So this is the same channel ladder I've shown by WHO. How to use morphine by the patient. This is also very important. Bring the remaining stock of the medicine and wrapper. Suppose a patient has been given 200 tablets for 15 days. So tell him to bring it back and tell him to record it. Take the medicine round the clock. Do not take all tablets at a time. Instruction about tablets on empty stomach and full stomach, and increase and decrease of doses. These things has to be taught. The side effects I have told you, management, common constipation, sedation and nausea, serious respiratory depression, and strategies, slow titration, monitor adherence and manage adverse effect. Myths, addiction, rare in well-managed cancer patients. It is myth. Respiratory depression were very uncommon. Tolerance does not significantly reduce effectiveness. So with these words, I end my talk. I hope you have understood the role of pain management by different methods in cancer patients and other palliative care patients, and role of morphine with caution as an ultimate line of treatment in palliative care. Thank you very much.